So you've just learned about the anatomy of the heart, and if you remember, the walls of the heart are made up of muscle cells that compose the myocardium. Well, what is the role of a muscle cell? You learned this in Anatomy 1. Remember, muscle contracts, and when a muscle contracts, its job is to move things throughout the body or to move the body. You learned about cardiac muscle tissue. The cardiac muscle tissue contracts and moves blood through the heart into and out of the heart. So let's look at how this works. Something has to stimulate a muscle to contract. When you learned about skeletal muscle, you heard about acetylcholine being released from a motor neuron and how that then triggered the depolarization of the muscle cell, the skeletal muscle cell, and it contracted and moved the body or moved pieces and parts of the body. Well, again, the heart is composed of muscle, the myocardium, but it's very different in its mechanism of contraction and especially in what stimulates cardiac muscle cells to contract. The heart myocardium has autorhythmic cells. Now, this is not all of the myocardial cells, but there are specialized patches of cells that are what we call autorhythmic. That means they generate their own rhythm of contraction. So these cells self-depolarize. You don't have to have acetylcholine to depolarize the muscle cell membrane and then lead to that whole complicated contraction that we learned about, right? So these cells self-depolarize and again are known as autorhythmic cells. The first patch of these autorhythmic cells is known as the sinoatrial node. Sometimes we just abbreviate that as SA node. So the sinoatrial node is located in the superior part of the right atrium. So just to remind you of your chambers of the heart, here's the right atrium and the left atrium. Remember, those are the receiving chambers, so blood comes into the atria fill, and then blood flows through your tricuspid and bicuspid valves into the right and left ventricle. Your ventricles are your ejecting chambers. When those muscle walls contract, blood is pushed out through your aortic, and you can't see it here, but your pulmonary semilunar valves take that blood, and blood goes out to the body in the systemic circulation through the aorta, and the pulmonary trunk would be right here. It's been removed so you can see inside the heart, right? But the pulmonary trunk would then take that blood out to the lungs. Okay, so just a bit of refresher because it's important when we start learning about this conduction system to understand the pathway of blood flow. So the sinoatrial node, that first patch of autorhythmic cells here in the right atrium, the cells are going to self-depolarize. What does a muscle cell do when it depolarizes? It contracts. Remember, the job of the heart, muscle contracts and pushes blood out. So this SA node fires a wave of depolarization that spreads throughout the walls of the right atrium, across the interatrial septum, and into the walls of the left atrium, down to the inferior part of the right atrium, where the second part of the conduction system, the atrioventricular node, is located. Now, you notice that you have two nodes here in the right atrium. So the AV node, being that second node, is going to be the connection between the atria and the ventricles as we continue along this conduction pathway. So once the entire walls of the two atria depolarize, then the atria contract a bit and push blood through your atrioventricular valves. Okay, so the atria have contracted. They push the blood through the AV valves. Now the blood is filling the right and left ventricles. The AV node gives rise to the AV bundle. Okay, so the AV bundle, and I'm sorry, this arrow's a little bit off. It should be pointing right here. The AV bundle is the connection between the atria and the interventricular septum. Remember, that's the wall that divides the ventricles. All of this is made of myocardium. Remember, that's the walls of the heart. So the AV bundle depolarizes, and that wave of depolarization passes down the AV bundle into the interventricular septum, where it branches into right and left bundle branches. So your right and left bundle branches serve the two sides of the heart and then give rise to smaller little Purkinje fibers. Now, again, these arrows are a bit off. The Purkinje fibers are the smallest little fibers out here at the ends of those bundle branches. Now remember, all of this that you see here in yellow, these stringy looking structures in the nodes, this is your cardiac conduction system, those autorhythmic cells. But all of the myocardium is not made up of autorhythmic cells. So if these cells in the conduction system depolarize, self-depolarize, how does the entire myocardium contract? Think back when you learned about the structure of cells and tissues and all back in Anatomy 1. Do you remember the connections between cells? Do you remember gap junctions? Your cardiac muscle cell has specialized structures called intercalated discs, and those intercalated discs are composed of desmosomes that anchor the cells very tightly together and hold them as that myocardium contracts. Remember, your heart muscle starts contracting from the time your heart is formed in the uterus until the day you die. So those muscle cells are constantly pulling against each other. The intercalated discs allow for that strong connection between the cells so that they don't pull apart. But the important part about the intercalated disc and the cardiac conduction cells, or the cardiac conduction system, are the gap junctions. Gap junctions. Gaps that form channel-like structures between adjacent myocardial cells. So when one cell depolarizes, ions can flow from one cell to another, to another, to another. And remember, when ions move into a cell, that cell can depolarize. So think of it very much as the way that dominoes fall. When one cell has an action, the next cell has an action. When one domino falls, it causes the next domino to fall. When one cell depolarizes, the gap junctions allow for the next ones to depolarize. Okay, so now that we've got the overview here, let's look at how this is going to work. The SA node depolarizes, and those ions flow from cell to cell through those gap junctions throughout the atria. The AV node depolarizes, and that wave of depolarization causes contraction of the atria. Blood is pushed through the AV valves. While this is happening, the AV bundle is depolarizing. It branches into your left and right bundle branches, so the myocardium continues to depolarize. The Purkinje fibers, the small little branches, are depolarizing, and ions are flowing out into the myocardium, and the ventricles contract. Contraction begins down here at the apex of the heart and pushes upward, or pushes the blood upward. So think of this as squeezing from the apex, and the blood is being forced back up. But it can't go back into the atria because your valves are closing. Your AV valves are closing. But as that pressure of the blood is pushing against the aortic and the semilunar valves, those valves open and blood leaves the heart. So far, so good? All right, so the conduction system, composed of those autorhythmic cells, depolarize the myocardium. And as we were looking at that cardiac conduction system, I mentioned that SA node first. Let's go back and look at that again. This is your SA node. Your SA node is the pacemaker of the heart because it depolarizes faster than any of the other structures in the cardiac conduction system. So it fires or depolarizes an average of about 75 times per minute. And that establishes what is called our sinus rhythm, or that rate of contraction. The AV node is also autorhythmic. It can self-depolarize, but it only fires about 50 times per minute, so it's much slower. So by the time it would get around to depolarizing itself, the SA node has already depolarized it. So the SA node, because it fires faster, is the pacemaker. The AV bundles and the bundle branches are also autorhythmic, but as you see, they only fire about 30 times per minute, so they certainly don't get to do anything on their own. The boss, the pacemaker, that SA node causes them to depolarize before they can depolarize on their own. Because we're looking at changes in electrical activity in these muscle cells, we can measure that with electrocardiography, what we call an ECG. Now, you may commonly hear this referred to as an EKG. K is the German beginning of the word cardio or cardiac, but we're not German. So ECG, because in the English language we spell cardi, as in cardiography and cardiac, with a C. Either one is correct, but to be more correct, it's ECG. You're going to hear EKG more in the clinical setting. But regardless which one you call it, an ECG is measuring electrical changes in the heart. And as it does so, the mechanical part of this that is connected to the big machine with all the electrodes is going to cause a drawing of waves. And we get three classic deflections that we call the P wave, the QRS complex or QRS wave, and the T wave. In a healthy heart, the size of these waves, how long it takes for one complete cycle, and how many of these cycles in a minute is pretty consistent. But when you see changes in the normal pattern, that can be indicative of damage to the heart, or perhaps there's problems with the cardiac conduction system and there are cells that are not depolarizing and contracting properly. So when you look at a typical drawing of an ECG, here you can see those three deflections: the P wave, Q, R, S, and T. So this is known as one cardiac cycle. So remember when we talked about the cardiac conduction system just a minute ago, we began with the atria depolarizing and contracting. Now think about this for a second. What is depolarization? Depolarization is caused by the flow of ions, and remember, ions have an electrical charge. So the P wave is measured when the atria contract. Then the QRS complex is the depolarization and contraction of the ventricles. And then the T wave is ventricular relaxation. Now remember, in order for a muscle cell to contract once, it has to reset, relax, repolarize so that it can contract again. So the T wave is where you see the ventricular relaxation and repolarization. Well, what about the atrial repolarization? Don't we need those cells to depolarize and reset? Of course we do. It's happening at the same time the QRS, the ventricles, are contracting. So you don't see a separate wave or deflection on the ECG that illustrates the atrial repolarization. So you can think of it as being hidden because the QRS, the ventricles, cause a much greater change. In addition to the three regular or normal deflections, the P, QRS, and T, you also have intervals and segments. A segment is the region between two waves, such as you see here with the ST segment. So it's the area between 2 points on a wave. An interval includes one segment and one or more waves. So if you look here, you've got the QT interval. So it includes the QRS complex with waves, segment, the ST segment, and the T wave. anything that causes the cells to not, or the walls of the myocardium to not depolarize properly. For instance, if you have a heart attack, a myocardial infarction, and some of the cells have been damaged, then those damaged cells are not going to depolarize. So the rate of depolarization, or the amount of depolarization in that area, would be less. So it would change the pattern of the waves. But what if your heart rate just gets faster or slower? Faster heart rate is tachycardia. Slower heart rate is bradycardia. What do you think is going to happen to the pattern of these waves? Well, if your cells are depolarizing faster, then your waves should appear closer together, right? Because your heart's going to be contracting faster. Okay, so let's continue on this, and we'll talk just a little bit more about the use of this ECG. Now, when you're looking again at these waves, you're looking at changes in electrical activity over a period of time. So the x-axis here, if you think about this in a graphical sense, because it is a graph, right? Here we have on the x-axis time, and on the y-axis how much electrical change, so up and down, right? So if we look at these two together, we can talk about how to use this information. Now, I mentioned on the previous slide how you can look at the pattern of the waves to see if there are electrical changes, if there's too much or too little depolarization. But if the waves are closer together or spread farther apart, then that means the rate of depolarization has changed. So how many times a minute are these cells depolarizing? Well, we've got to have a standard way to look at that. So we use this paper on the electrocardiograph that is divided into sections. So you see first these teeny tiny little boxes. These teeny tiny little boxes, and remember the x-axis is time, each one of these tiny little boxes is 4/100ths of a second. Wow, that's pretty quick, right? You also see that we have large boxes, okay? So this is easier to see here when we don't have the waves. The large boxes are 5 by 5 of the teeny tiny small squares. So this is 0.2 seconds, and if you have 1, 2, 3, 4, 5 large squares, that is 1 second. So because we know how much time is represented in these squares and in these boxes, we can calculate how many times an event, a depolarization, repolarization, and therefore contraction is happening over a period of time. So the easiest way to use an ECG to calculate heart rate is to use the 1500 method. Now, there are other ways that you can multiply by a factor of 0.04 or 0.2, but I find the 1500 method is the easiest. If you've been taught clinically another way to do it and you're comfortable with that, by all means use what you're comfortable with. But here's the simplest way for those of you that may be just learning. So you look at, we'll go back for just a moment here. You look at the ECG strip, okay? Now remember, you count the tiny little boxes. So what we're going to do is to find two peaks that are very similar, or the same peaks in a regular spaced ECG. So we're going to count the number of small squares from two of the same peaks. So let's say we choose P waves, or maybe we choose R waves, but you always want to make sure you have the same thing. You choose P waves, R waves, T waves, whatever. R's are very easy, P's are usually very easy. So you count the number of small squares between those two waves, and then you divide by 1500, because 1500 is the number of small squares in 1 minute of ECG time. Sounds like a lot, right? But yeah, remember how tiny those squares are. Now this works if heart rate is regular. If the heart rate is not regular, you don't have a normal sinus rhythm, then using this method is not reliable for calculating heart rate. So let's look at an example of this. So here we have an ECG strip, and we're going to use the 1500 mechanism for this. So I have chosen, to use the R. So here we've got an R, here we've got an R. Again, you could use P to P or T to T. I like the R's because it's easy to see. Now remember, each large box has 5 small squares, so we've got 5, 10, 15, and then go back 16, 17, 18, 19. So there are 19 small squares from the peak of an R to a peak of an R. So 1500 divided by 19 means that we have an approximation of 79 beats per minute. Practice this a few times, and remember, this only works if you have a regular, normal sinus rhythm. What we've been seeing on the ECG, our P, QRS, and T, represents one cardiac cycle, or what we commonly think of as one heartbeat. So here we have 1, 2, 3, 4 cardiac cycles. So a cardiac cycle consists of systole and diastole. Systole refers to contraction. We know that cells have to be depolarized in order to contract. Diastole refers to relaxation, and that is when our cells are repolarizing. So one complete cardiac cycle or heartbeat consists of atrial systole, where the atria depolarize and contract, and the atria diastole, repolarize and relax, followed by a ventricular systole, or the atrial diastole and ventricular systole actually coincide, but the ventricles depolarize and contract, ventricular systole, followed by ventricular diastole, relaxation. Now let's think back to heart anatomy again. Remember, we've got the atria and the ventricles. The atria receive the blood, the ventricles eject the blood, and between the two we have the AV valves, your bicuspid and tricuspid valve. Exiting the heart when those ventricles contract, you have your pulmonary valve and your aortic valve, and those are called your semilunar valves, right? So when you're auscultating or using a stethoscope to listen to heart sounds, you hear a specific pattern typically referred to as lub-dup. Now, what are you actually hearing? Sounds sort of like little drums being beat on in there. Well, it's very similar to that. You have something smashing against a surface and creating a sound. So when you hear that first sound that we referred to as lub, the atrioventricular valves are closed. When the AV valves are closed, the ventricles are contracting because the ventricles just depolarized. When the ventricles contract, they push that blood from the apex back up toward those AV valves. But the AV valves are pulled closed. And as the blood hits those AV valves, it causes that deep lub sound. So that's what you're hearing with the first heart sound. The AV valves are held closed so the blood can't regurgitate or backflow into the atria. The blood has to push against the semilunar valves, your aortic valve and your pulmonary valve, and then move into the aorta and the pulmonary trunk. Now, once the ventricles begin their emptying, the pressure in the ventricles decreases, but the pressure in the aorta and the pulmonary trunk has increased. Now, due to that increased pressure in those arteries, as well as just gravity, some of that blood falls back down onto those closed semilunar valves, and you get the much sharper dup sound. So lub-dup, lub-dup, lub-dup. That is what we refer to as our heart sounds. There are certain areas that we can use that stethoscope to auscultate heart sounds better in one area or differentially in one area as compared to another. So when you hear the normal heart sounds, that is usually indicative of properly functioning valves. But if you want to listen to each valve, perhaps you suspect that there's some congestion or there might be a murmur. So you've got sort of a gurgling or swishy sound. Well, we need to determine which valve is insufficient in its functioning. So by using particular spaces, we can hear these valves best. So if we want to hear the sounds of the aortic valve, you move to the second intercostal space at the right sternal margin. By placing your stethoscope in that position, you best hear the aortic valve. The pulmonary valve sounds are best heard at the second intercostal space on the left sternal margin. So you're hearing those semilunar valves on the right and left sides of the sternal margin at the second intercostal space. Remember, intercostal means between the ribs. Lower to that or inferior to that at the fifth intercostal space, you can hear the mitral or bicuspid valve best. If you move right here, fifth intercostal space, okay, and that of course is on the right side, and here you hear the tricuspid, or I'm sorry, that's on your left side. I'm not thinking as I'm doing this, I'm reading ahead. Here on the right side, of course, in correct anatomical position at the fifth intercostal space, you hear the tricuspid valve best, and on the left side here, you hear the bicuspid valve or the mitral valve best. And when you do hear those murmurs, that can indicate that you've got backflow. So rather than those valves closing properly, they're allowing blood to flow back through instead of closing off. Another way that you can assess circulatory efficiency is to use pulse points. So pulse is simply the rebound of an artery. Remember, when the heart contracts, the left side of the heart, that systemic pump is pushing blood out through the aorta to the arteries of the body. Artery is taking blood away. So there are areas where you have more superficial arteries that are easy to palpate. So the temporal, facial, carotid, brachial, radial, femoral, popliteal, posterior tibial, and dorsalis pedis are some of the ones that are most easily palpated. And by feeling that rebound of the artery as the blood is pushed out through that artery and the artery expands and then rebounds or recoils, you can monitor heart rate. The most common of these, of course, are the radial artery. You've probably all had or performed a pulse check using the radial artery, and also the carotid artery is very common as well. Depending on what's going on with the patient, if you're assessing blood flow to a particular area, you may access an additional pulse point. So how do you determine heart rate from pulse? Well, you simply count. You count the pulses flowing through that artery for a period of time. Now, no one wants to stand around for a minute, 2 minutes, 5 minutes to simply count. So you count for a specific period of time and then multiply by the appropriate factor. So if you do a 15-second count, you multiply by 4. If you do a 10-second count, you multiply by 6. And that gives you how many beats per minute. All right, let me get the slide to advance. Hang on. All righty. Additionally, we can monitor cardiac function and assess cardiac function by looking at blood pressure. Pressure is a measure of how much something is pushing against something else. You've all felt pressure. You felt pressure to perform well on your test. You felt pressure on your job. Well, what is it? That's something pushing you, right? Pushing you to do harder, to do more. Well, pressure in the sense of blood is the pushing of the blood against those vessels. It's measured with systolic and diastolic pressure. So your diastolic pressure is the pressure of the blood in those vessels when the heart is relaxed, and your systolic pressure is the pressure of the blood when the heart is contracted. We measure blood pressure most commonly using a device called a sphygmomanometer, what we commonly call a blood pressure cuff, and a stethoscope. So we use the sphygmomanometer to pump blood or to pump air into a cuff, and that cuff, when it's wrapped around the upper part of the arm, will completely occlude or close off that brachial artery. Then we use the stethoscope to listen for sounds. So normally when the vessel, the brachial artery, is completely opened, we don't hear blood flowing through that vessel. But if we restrict that blood flow and then slowly release the pressure in the blood pressure cuff while listening, we can hear a popping little sound called the sound of Korotkov that indicates that blood flow has been restored back through that artery. So that is the first sound that blood makes when it comes back through, and that is the highest pressure. That's our systolic pressure. Now you have to continue to listen, and listen very carefully as you're watching the gauge to see at what point you hear the sound of Korotkov and where you stop hearing the sounds. When blood is completely restored, blood flow is completely restored, you no longer hear a sound. That last sound you hear is your diastolic pressure. So that gives you your systolic over diastolic pressure, measured in millimeters of mercury. Now, again, I mentioned you have to listen carefully. If you're not paying close attention, all of a sudden you don't hear the blood flow anymore, and you don't know where that diastolic pressure was. Once you have your blood pressure, you can use that to determine pulse pressure. So pulse pressure gives us an idea of the proper functioning of those arteries and the elasticity of those arteries. Can the arteries expand and recoil, rebound as that blood is being pushed through them? So in order to get our pulse pressure, you take your systolic pressure and subtract your diastolic. So let's say that our blood pressure was 120 over 80 millimeters of mercury. If you take 120, subtract 80, that gives you a pulse pressure of 60 millimeters of mercury. So when you have an increased pulse pressure, that can indicate that the arteries have been damaged, or that you have atherosclerosis, a hardening of the arteries, where you have less elasticity and less ability to expand and contract. Anything over 60 is considered abnormal and can be used as an indicator to show that you may have some type of circulatory damage. And then our final assessment associated with cardiac function that we want to look at is the mean arterial pressure, or MAP. Most of the time, blood flow and blood pressure is pretty consistent within an individual. But mean arterial pressure is an average that gives us a better assessment of that pressure. So in order to get our mean arterial pressure, first we have to begin with that blood pressure. So we get the diastolic and systolic pressure, and we figure the pulse pressure. So to use those numbers to get our MAP, we take pulse pressure. Now remember, that was your systolic minus your diastolic. So a while ago we had what? 120 over 80. So that gave us a pulse pressure of 40. So if we divide 40 by 3, that gives us 13. Okay? So pulse pressure, remember, was systolic minus diastolic. That was 40. Divided by 3, that gives us 13. Then add the diastolic pressure to 13. So our diastolic pressure was what? Do you remember? 80. So if we take that 80, add it to 13, that gives us a mean arterial pressure of 93 millimeters of mercury. Now, that is within our normal range. Okay, a mean arterial pressure of at least 60 is necessary to be sure that tissues are perfused, that we get oxygen out to the brain for proper functioning, to the coronary arteries so that the myocardium is supplied with oxygen, and also out to the kidneys, because remember the kidneys are going to serve to filter the blood. So if the pressure is too low, not only are the organs, the brain, the heart, and other organs suffering, but the kidneys can't function to filter without proper pressure. Filtration rate decreases, waste products build up in the blood, and of course, once this begins to happen, your patient is in or could possibly be in grave danger. So mean arterial pressure gives us an average measure to compare normal and to look for those signs of abnormalities associated with cardiac function.